which is always something that will have several points of view. I'll go to a less non-controversial kind of topic. Now, by nature of this talk on VA ECMO is something that typically can be addressed better by a workshop. So the idea over the next 20 minutes would be to place in few concepts which will help inform your practice, to help you when you're faced with your next patient for whom you're considering or you're managing VA ECMO. And rather than actually going through every particular thing that we deal with when you're managing patients with VA ECMO. Now, next slide please. The slide change is not working. Slide please. Of managing patients with heart and lung failure. And this is true especially in my practice where my practice is based on a heart and lung failure unit. So our choice of extracorporeal therapy would be dependent on what exactly we are managing and what is the underlying disease in which we are managing. So when, for example, we are faced with, say, a bad COPD exacerbation that is persisting or a very bad CO2 retention, you could just get away with kind of something like a core, which is not often needed but can be done. Even with several juridic ways it can be done, say for example the dialysis surgery. In the context of a heart lung transplant program, this can be a particularly big problem in patients with obstructive lung disease who are very, very advanced. So in that setting, Gopalan is a therapy which we talk about as we go, is something that we use as an intermediate term to bridge patients. As patients develop more hypoxemic respiratory failure in the context of severe ARDS, then one uses the traditional VV ECMO. And if the requirement is not, if they are failing early, then you could get away with using a single like Avalon or equivalent IJV cannulation itself. Now, as the hypoxic respiratory failure worsens and the RV takes a hit, then these are the patients then you end up supporting by VA ECMO initially. Or if there is a primary LV issue related to a heart cardiac thing, then these are patients in which you would use VA ECMO. Bear in mind that you need ECMO for circulatory support as well as you're providing oxygenated support because you're doing a right to left shunt by doing an ECMO. But there could be situations where you don't need the oxygenator, so you need an isolated ventricular circuit when you're managing patients with primary cardiac issues. So those are the other supports that I have put in, and we'll be talking about this as we proceed with this next thing. So first, who benefit and who don't. So in the larger context, there are patients with primary cardiac issues who will benefit. Now the choice of who to take up for VA ECMO would is something that will improve with experience. There are certainly guidelines available for you to go through. For example, there is a kind of a score, SAFE score, which is published based on a retrospective study cohort, which can give you a number. Say, if the numbers are not positive, then the survival out of this procedure is more than 75%. We have negative scores going into the ECMO initiation, then the survival is a decimal 20% or lower. I for one, for example, use something like the Alfred model, like a semi-quantitative score. So somebody who's younger certainly will benefit. And again, the thing that determines is, of course, would be the primary indication. So in the context of a pulmonary myocarditis, a context of a severe pulmonary embolism, or a post-procedure, situation, or a first position of cardiomyopathy where the patient has not been in and out of ICU several times, these are the best patients who would, who would improve with this kind of therapy that you are offering. But it's also important to qualify against three group of qualifiers. One is what are the acute modifiers? Acute modifiers are how late is the presentation. So the patient already significantly has circulatory issues related to the hypoperfusion that he's already had before meeting you or before ECMO is considered, then they do poorly. And what are the chronic modifiers? These are, bear in mind, often patients who have underlying cardiac heart and lung issues. So if they have previous significant COPD, chronic lung disease, and chronic kidney disease, then these are patients who are less likely to come out of your therapy. And of course, there are certain absolute contraindications like advanced age and everything, which makes this rather futile. So, like I said, you could use certain scores which can help you in a numerical way, or you could use the semi-quantitative way of looking at this thing. And of course, as you apply this therapy more and more, we tend to get better at it. So, very briefly on physiology of VA-ECMO. Now, this is the oxygenation part of it, and that's very similar to VV-ECMO, except that here it's it is in, you're adding a circuit in parallel to the existing circuit and not in series like in VV-ECMO. So when you in VA-ECMO, you're taking blood out of the venous side and putting it on the arterial side. The cardiac output is here a sum total of the native cardiac output plus the ECMO circuit, and the oxygen delivery is basically this cardiac output content into the total output that is being delivered. Now, provided the native lung is normal, then the oxygen put into the circuit from the native lungs versus the ECMO circuit will be almost dependent only on the relative proportion of cardiac output. So if you look at the SpO2 and you look at the peripheral saturation, if the ratios are extraction is less than usually it's 5:1, which is VO2 to DO2. If it is better than 1:3, that is its extraction is no more than 2 times, then you're good. You're likely to be good. But this is true only if there is no latent underlying lung disease. So there is a lot of pulmonary edema, there is underlying lung disease. Then you can no longer use this particular calculation to inform your practice. So that is very briefly about extraction and supply dependency. More importantly, when you speak about VA-ECMO, you are interested in what is happening to the heart. So in a patient that, so these are curves on the left hand side, you can see a normal curve, and you can see the relationship between the LV volume as well as the left ventricular end-diastolic pressure. In patients with acute cardiogenic shock, now this curve is shifted down to the right. That is, for a given, to generate a given pressure, the LV then has to, it works on a much larger left ventricular end-diastolic volume and is able to generate much lower cardiac output as well as much lower pressures. Now, this curve is shifted slightly up in patients with chronic heart failure, but will be slightly even lower in the acute cardiac failure if there is a chronic heart failure on top acute and chronic heart failure. Now, by doing VA-ECMO, what you're doing is introducing this series, and that actually supports and decompresses the right heart. But what it does not do is support the left heart very well, especially if that heart is study. And why is that? So look at several indices as we institute VA-ECMO here. So on the left hand side of the pink is the flows as we increase with VA-ECMO, starting from 1 liter to 4.75 liters, which is full cardiac support. Look at what that does below to several other indices that we've been talking over the last 2 talks. So first is the aortic pressure, which is a reflection of like SVR or basically that is blood pressure maintenance. That's what we're interested in while instituting VA-ECMO. So we are maintaining pressure because we're providing a large flow into the patient's arterial tree. So the aortic pressure keeps going up from hypotension to 100 here. Corresponding to this, you can note that the green line, which is the left atrial pressure, is also going up. And the right atrial pressure is actually going down. That is because the right side is being decompressed. Blood from the right side is being taken and put through the oxygenator and given to the left side. So the right side is very well decompressed and the pulmonary blood flow is well controlled. But what is happening here is very important. So as the ECMO flows increase, you can notice that the endogenous LV volume native is actually going up, and the amount of pressure for that given volume is actually increasing, and this is increasing with amount of ECMO flow. So ECMO, when you institute ECMO, is as something which can be stressful because you are acting against you are putting all this blood into the aorta, so that is actually increasing the SVR for that particular heart. So if you are doing this in a situation in which the heart is terribly stressed post cardiectomy, you should be aware that the LV may not be, maybe totally not be, maybe not able to work very well. So you will have LV which is stopping to work very well, not opening, aortic valve may not open, so you will end up developing clots both in the LV and as well as the aorta if it's not very well working. The coronaries are supplied to the native tree because it is at the cusp. So even though you're putting a lot of oxygenated blood into the descending aorta, you will not be supplying the coronaries, so you can end up ending myocardial ischemia. Depending on where the zone of mixing is, because the zone of mixing is you're putting oxygenated blood into the aorta, but the native blood is from the patient's heart. That output is not very good. So you have deoxygenated blood, especially if there is pulmonary edema, coming out from the patient's heart, and this watershed is where these two mix. So if the native output is very good, the watershed can be very close to the ascending aorta, but it will still not be at the cusp, it will be at the arch. So then the right heart, the right hand as well as the brain will still get predominantly deoxygenated blood along with the coronaries, and that is what is something to look for. So whenever you monitor patients with VA ECMO, always look at the right limb saturation and right upper limb blood pressures. And of course, the primary reason to put ECMO is cardiac recovery, and this physiology of stressing the left heart is not very good or conceptually for cardiac recovery. So how to look, and this is crucial when you're putting the ECMO, how to look and see whether the LV is working well while this patient is on VA ECMO. So if you actually if there is the LV wasn't terrible, then you might actually get off. The VA ECMO might actually help this patient because you maintain some filling pressures, you maintain circulation, and the heart is compensating. So you will find on the what is in green. So you'll find that the arterial on VA ECMO there is still some pulsation which reflects the endogenous cardiac output. SpO2 is good, means extraction is not terrible, so there is no supply dependency, so it is still more than 55%, close ideal is 70%. CVP is okay, 8 to 12 millimeter, and on echocardiography you will find that there is the aortic valve opens well with contraction, IV cyst are terribly dilated, IV system collapses, and on most of these patients have Swan gans in place, and you will find the LA pressure or surrogate is not very high, and the X-rays should show the other way. So X-ray is not showing alveolar edema, showing redistribution, but not frank alveolar edema. But if you have, on the other hand, completely, LV is completely calm, you will find that the CVP goes terribly high, the extraction is very, very high, and the pulse, there is absolutely almost no pulsatility, indicating that there is no native cardiac output. So then these are situations in which you need to decompress the LV, because the LV will then keep on increasing in size, will stop contracting, and that's when you have all sorts of clots and other issues with the left ventricle. So there are, how do we decompress this left ventricle should this happen? So there are several ways, some of which we apply routinely. So on the left top, you can see the patient, the violet indicates cardiogenic shock, and the red indicates ECMO when that is instituted in the setting of cardiogenic shock, and that is how ECMO improves cardiac output in this situation. But you will notice that LV volume has actually increased while ECMO has been instituted on this. So along with this, we always keep a watch, and then these are some measures you institute whenever ECMO is instituted. Like for example, always consider vasodilators should your blood pressure allow you to do that, or at least make sure you are not using too high ECMO supports. You use the ECMO support that is just enough to keep your perfusion pressure reasonable, that is 65 to 70. So that is what is shown in C. So you use vasodilators or you use a lower setting of ECMO to get the map reserved, because the afterload is what is acting, your heart is acting against that particular afterload and SVR. You can always use inotropes, but that is flogging a heart where it's not likely to work, so that's not as effective as, say, using a vasodilator, should that be possible. There are other ways of doing it, like for example using IABP, but that's almost not done in most settings except in like acute myocardial infarction, etc. The post in the setting of a heart transplant or heart lung transplant, should this be a particular problem, and the usual solutions are to use a surgical vent, which is a LV vent, and splice it to the venous side, or use a sort of a temporary device like an impeller. Typically, you need a distal perfusion cannula, which is what is shown in white here, which is perfusing that particular limb. And monitoring for low limb saturation and pulses is strongly recommended. We typically use a Doppler to monitor for pulses. Saturation is primarily if you are worried about over perfusion and hyperoxia for the lower limb. And I've already spoken about the blood pressure waveform and the watershed zone in relation to this. Next, I was speaking about this particular the distal cannula and splicing into this circuit. Now, increasingly we are using this particular cannula, which is the Livonova cannula, which is a 19 French cannula, which has a hole at the for a distal perfusion. So this kind of negates the need for a distal perfusion channel on the arterial side itself. So what this also means that this, if it is a planned kind of thing, then you can use this cannula because we require radiographic position. So most of our elective, semi-elective VA ECMOs, we now do it in the hybrid cath lab where we have access to fluoroscopy and access to ultrasound. But if you have a crash and burn situation, then use kind of bedside ultrasound and bedside TEE, which I will show you next. So, as opposed to peripheral ECMO, which we spoke about now, this is central ECMO. Central ECMO is when you take out blood from the central tree like IVC or the SVC or both often and then put it into the aorta. As can be understood, this is something that is done in the context of a cardiac surgery, typically a heart transplant or a post-cardiectomy kind of thing. When the patient fails to come off the pump, for example, then you expect the heart to improve over the next few days. Then you can leave this patient on a central VA as opposed to putting this patient on a peripheral VA. How is this different from a cardiac pulmonary bypass? This is different because there is no chamber, there is no peripheral chamber where blood can be stored. It is done for a longer period. It is done with a centrifugal pump as opposed to a roller pump. And these are the kind of small differences, but it makes a big difference in terms of how we approach central kind of CBP. And by definition, because central CBP are putting the blood back into the aorta, there is no possibility of redistribution. Or upper limb or brain hypoxia because most of the blood is smack bang. Avoid upper limb and brain hypoxia. And these are the other ways I've talked about. The LV dysfunction and RV dysfunction, these are other things that you can use. We've already talked about vasodilatation, judicious use of inotropes and diuretics, and reduced ECMO flow. These are things that you do always in all patients. But provided if the LV function is deteriorating or worsening on this, then your options are these three things. You can use IVP, you can use LV vent, or you can use an impella. Increasingly outside the immediate surgical setting, we are using an LVAD or a LVAD impella to improve the RV as well as the LV function in the context of a bridging program. And I'll show you how that is. So this is the configuration. When you're doing a VA ECMO, you're drawing blood from the right side and then putting them into the left side. Here the aorta is shown because it's a central cannulation, but you have the femoral artery in the traditional way. In the central, it can be put into the aorta directly. Now, if there is LV dysfunction, you are splicing the LV into the venous side, and that is decompressing the heart as well, and then that you are supporting by using the LVAD. Now, if on this circuit the patient improves, the RV tends to improve faster than the LV sometimes, and then you can just get rid of the RV side. So you can just remove the right ventricular side and use only this without the oxygenator because you're no longer doing a right or left turn, then that will just be a LVAD. So you can use a centribag in this configuration, and it's almost similar to using a LVAD in a temporary situation. If, for example, you have problem only with the RV, then you can remove that aorta thing and put it into pulmonary artery. And that is just basically an RVAD. If you use it without an oxygenator, you are just providing an RVAD with a centribag. If you use it with an oxygenator in the setting of a lung disease, then you're using an oxy-RVAD kind of configuration. We have now devices which can do that with a single-stage cannula, for example, the Protect Vivo. So this is single-stage cannula that is inserted to the IJV and goes into the pulmonary artery. The inflow into the circuit is from the IJV, and that is passes through an oxygenator and then is given to the distal into the pulmonary artery. So that completely decompresses the right ventricle. But of course, we can do it with our Centrimax by using a two-stage cannula as well. And this is something that is infrequently used in India, but used quite a lot abroad. Sorry, when the earlier slides are moving. So that is something called the Nova Lung. So Nova Lung is something that is used specifically in the setting of severe pulmonary hypertension when the RV is simply not contracting and causes hypertension. So you put these patients on VA ECMO. And the problem with VA ECMO is you cannot mobilize these patients, and if you cannot mobilize these patients, you cannot actually end up doing a transplant. So what you do is you have to do a sternotomy and put a PA relay shunt. And often these patients then improve, and then you're able to get the VA ECMO off. And you're completely decompressing the right side, and provided the left side is normal, which it should be if they're going for a lung transplant, you should be able to get these patients mobilized and walking for a lung transplant. This is something that we are increasingly using post in the setting of a heart with the both it can be used on the left side as well as the right side. This is shown on the left ventricular impella mechanism. This is percutaneously implanted with the cardiologist and can deliver 2.5 liters per minute. If you want more than that, then it has to be surgically implanted to the cardiothoracic surgeon. So this is a summary of all our particular options in the setting of VA ECMO. So this, if you've not followed what I've said so far, this is a nice way to recap what we're doing. So if you have hypoxic respiratory failure, all you need is a VA ECMO, and that can be dual stage cannula or it can be a single cannula depending on our requirement and of oxygenation. If you have worsening heart failure, then typically we can change this to a VA ECMO, and because there is underlying lung disease, they're going to a LVAD or otherwise. So general management and decision pathways, last couple of slides. During ventilation, we always, like as in any patient with lung disease, so we would apply low tidal volume ventilation to avoid pulmonary edema. We promote mobilization and consider extubation if in a very careful setting. In VA ECMO, it's possible. In VA ECMO, it depends on the right heart. So if the right heart is not doing well, then extubation is a problem because peak application is crucial to managing these patients. And otherwise, anticoagulation with kind of prescribed protocol based on ACT and APTT monitoring. Neuro monitoring, we try and keep these patients awake so that we can monitor them. And careful monitoring for the lower limb ischemia as well as brain ischemia because of the configuration is important. Important to consider drug dosing based on the altered pharmacokinetics in the ECMO circuit, especially for antibiotics. And we try to keep patients as neutral negative balance as possible. If dialysis is required, we can splice it to the ECMO circuit. We don't need to institute extra lines. So depending on where your patients are, if it is a bridge, most of our patients are bridge to recovery. So they come with an acute issue, and then you institute VA ECMO, you expect them to improve over the next 3 to 14 days. So that would be a bridge to recovery. This can increasingly in Western world is being done in the context of out of hospital cardiac arrest, where it can be done as part of the CPR, so it's called ECPR. Sometimes this is often done as a bridge to decision, so you don't know how good or bad the underlying heart is, and then you're waiting for them to declare themselves. In the setting of our transplant program, we often have to do this as a bridge to either a device or a transplant, provided patients don't have any of the attribute contraindications that are initially talked about. And when you wean patients, and in the context of a bridge to recovery, these are the usual kind of things when we start weaning patients. If the primary process is improved, there is no intercurrent process. Clinical parameters show stability. There are very low supports, and these are the ones that we use as cutoffs for our low supports. And these are the common inotropes and vasopressors that are used in our unit. We do almost daily echoes on these patients, looking at the LV as well as the RV and the valves. And ECMO support is minimal. By minimal, I mean it's typically less than 2.5. We then come down to about 1 liter and leave it at no lower than 1 liter. Beyond that, we take the patient to OT, where we do a brief clamping trial to see how the LV is doing, how the blood pressures are doing, and then we are able to take off. The problem with VA is you cannot stop it because it will clot and then you will have a disaster. Unlike VV, where you can put the oxygenator off and run the circuit, where in VA you can't do that. We almost always decannulate in data. We never do a decannulation in the IC. And complications, very briefly, issues with the artery, as well as your problems of LV issues and hypoxemia, brain hypoxemia, which is more than what you'd expect in a VV ECMO. So, briefly. All this work is possible thanks to my team, and I'd like to thank everyone in the team who's made this possible, and ISCCM for inviting me here. Open to questions. Thank you.
Thank you. Thank you, Dr. Srinivas, for the
because we usually it's placed under contrast with some contrast in a fluoroscopic circuit. So you're able to see and they're able to monitor. So with levodopa, we've never had an issue. Whenever you put a 19 in or a 17 or higher in a male, the first thing to do when we have a limb ischemia is to make sure that the pulses are there or not there. So, I'm assuming, for example, in this instance, the pulses are not there, which means that there is a clot. So the next step is we go back to hybrid lab to make sure and give contrast and see where it is blocked. So if it is, we identify a block very proximal, which we are able to get out with the Fogarty, we call the cardiologists or vascular surgeons to do that. But if it's a long segment or it's distal and it's not amenable to intervention procedure, then we have to go to OT or the same hybrid lab. We open up and then we sort it out. Yeah, limb ischemia is dangerous. In several series, it's reported almost 15 to 16%. We certainly have not had many with the recent ways in which we used. So most of it is careful upfront cannula positioning. So and with the current cannula, we are really not having much issues. If the positioning is fairly good.
Do you have any best intervention to decompress
So there is no single best answer. The answer will depend on what is the context. So if you, for example, you are doing this in the context of most intensivists, that you're doing it in, say, a drug toxicity or a first presentation of myocarditis, you put this patient on VA ECMO and then you find that the native heart is not at all contracting, it's descending. Then that would be, the solution would be a LV impeller. That would be the best in that context. Now, if you're doing this in the context of a heart transplant, say, you put this patient on a central VA because patient you failed to come off the pump, and you put the patient on central VA, and then you came to ICU with this, and you find that the LV is getting distended. Then there is no sense in putting LV impeller at that time. All we do is then you put a vent into it and splice it to the venous side and wait. We can clamp the cannula depending on how much is the distension. So you can see the echo, see how the LV is doing. If it's completely decompressed, you need some LV filling as well. So you clamp it accordingly, putting some resistance in the cannula catheter side to decide your amount of LV that you need to be distended, because that will produce some native cardiac activity. As it improves, then you can remove the LV cannula for the vent first. And then when your hemodynamics are better, you are able to decannulate the ECMO circuit, and which is how we've done in PGDs in the heart several patients. It's not as bad as it sounds.
Sir, two questions. One is like regarding this limb ischemia. How frequently you are using these grafts for cannulating the artery? Are you directly cannulating with a graft? That is one. And second thing is like in VA ECMO, there are like in VA ECMO there will be two issues. Like one where heart and lung both are involved, and conditions where only heart is involved. When the heart is involved and we are keeping the flow on the higher side, let's say more than 2 or 2.5 liter or so, then the afternoon will be significantly increased. There will be a back pressure on the LV, and maybe that will transfer to your RV side also and coordinate and all that there. So what will be the best way to manage those kind of cases, and hardly in any way VAB you are told?
So two questions. The first question is about the distal limb ischemia, whether using a graft is better. Now, typically when you do a VA ECMO in a crashing down situation, you're using the femoral artery cannulation on the artery because the right side is straighter, so your venous, you would like the outflow not to be kinked. So use the right side vein and the left side femoral artery. Now, in this situation, there is no need for a graft. One, the nature of the procedure will preclude a graft because you are doing a crash and burn. You want the cannula in the next 5 minutes. So there is no graft. The problem here is if you use this circuit for months together, as has happened in patients with, say, post-COVID, I've heard of several references like that. We've never had any patients like that though. But if you use this cannula for long without a graft, then you will have all sorts of issues around the artery because this cannula was not designed to be in the artery for months together. So in that instance, you may have to go to theatre back to change it to the graft or resite the artery. So that is going to be a major issue because especially the underlying heart along has not recovered. We typically use a graft only if you're cannulating the subclavian artery or the axillary artery. So that we put a Dacron graft and cannulate to the graft because that is intended to be kept for months together. That is a upper limb kind of a VA ECMO for patients who have harlequin or who are being switched to a lung transplant. So that is the answer to the graft. Now, as far as the second question is concerned, this is what I was trying to talk about. When you are using flows more than necessary, you will be increasing the upload for the native heart. So the answer is you always use the lowest flows that is required to keep your perfusion okay, as by flows okay as per your clinical practice. So your oxygenation is good, in terms of your mentation is good, your urine output is good, your SpO2 is reasonable, is about 45 to 70%, and your extraction isn't too bad. Then you accept those levels of, you're not going to get a nice, beautiful number, you will accept. Whatever is acceptable, you will get. If that's acceptable to you, you use that lowest level of dose. Be that by 1.5 liters, 2.5 liters, or 3 liters, whatever is lowest, you accept that, rather than trying to get a perfect number with a higher dose. So that is one particular thing. But despite this, you will have issues of LV depending on the native heart. So if you're putting this in a patient with myocarditis whose heart is not at all contracting, even if you use a flow 1.5 or 2.5, you're going to have this problem. In that instance, you use other devices to decompress the heart, which is what was already discussed, using an impeller or etc., or using LV vent, or using venopercutance cannula spliced to the venous side has been described in the literature.